Hi everybody, DentalXP friends. This is Dr. Fabio Manuel Filannino speaking. I come from Italy, precisely from Milan, where I live and work most of the time. I grew up and graduated in the center of Italy, East Coast, where I'm still working as a consultant surgeon in colleagues and friends' offices. First of all, I want to thank DentalXP and Dr. Maurice Solama personally for inviting me to make this video for all of you. I hope you will find it interesting, and I hope to contribute to the knowledge and to the achievement of the best restorative therapies about implant dentistry for our patients. So, let's go straight to the point. This lecture is about a machine called Magnetic Mallet that is a device based on an European and US patent of invention in oral surgery. It uses magnetism to generate a very important acceleration of the osteotomes that maximize the forces applied to the bone, making the procedure fast and efficient, and in the meantime minimizes the inertia and discomfort for the patient. Such speed doesn't cause any bone eating, therefore irrigation solution is not needed. It's about 5 years I perform surgical procedures such as osteotome technique, split crest, or extraction therapies using this machine. That is also more precise for the reason that you can manage it using both hands and activate it by a foot switch than the traditional manual mallet I've been using since the beginning I started to put implants in 2001. Of course, the magnetic mallet has several tips of different shapes and diameters, as we can find in pretty much all the osteotome kits we met and we have used during the years, to manage the native bone and to move it apically and around the implant. We have straight tips for the frontal and curved tips for the posterior areas. We have different diameters of conical tips for placing, in my opinion, any kind of implants. We also have several tips for the split ridge technique, and I think we cannot ask for more shapes for this issue. Some of those can be utilized for the extraction of the dental roots, especially for the ankylosed ones. We have, by the way, a complete set of tips for this specific purpose. All those tips go to the same tool and you can change them in few seconds. As a matter of fact, the specific instruments available with the device have been designed to be used in the different practices, guaranteeing a complete set of instruments suitable for every kind of surgery. So what? Which is the difference between the magnetic mallet and the traditional manual hammer? What about the BPPV, benign paroxysmal positional vertigo, associated in the literature to the use of the hammer during the sinus lift procedures or osteotome techniques? Is that strictly related to the percussions? Or, as a matter of fact, we can have the same clinical manifestations performing a lateral window or simply drilling with burrs or piezosurgery? How much is important the hyperextended position of the head of the patient during the surgery? Well, before talking about the machine, let's see what we have on the scientific literature about BPPV and its symptoms after surgical procedures. In this article, we can find all the information about it. It's a clinical practice guideline on the PBPV from the American Academy of Otolaryngology, Head and Neck Surgery, year 2017. What is the BPPV? Benign paroxysmal position vertigo is the most common inner ear problem and cause of vertigo or false sense of spinning. It is a specific diagnosis and each word describes the condition. Benign, it is not life-threatening, even though the symptoms can be very intense and upsetting. Paroxysmal, it comes in sudden, short spells. Positional, certain head position or movements can trigger a spell. Vertigo, feeling like you're spinning or the world around you is spinning. Why do we have BPPV? There are crystals of calcium carbonate that are a normal part of our inner ear and help us with our balance and body motion. BPPV is caused by the crystals becoming unglued from their normal place. They begin to float around and or get stuck on sensor in the wrong canal part of the inner ear. The most intense part of the BPP symptoms have to do with how long it takes the crystal sensor to settle after you move or change your head or body position. As the crystals move and settle, your brain is getting powerful, false messages that you are violently spinning. Is that BPPV common? BPPV is very common. It is more common in older people, and many of us will experience it at some time in our lives. What are the causes? Most cases of BPPV happen for no reason. It can sometimes be associated with trauma, migraine, other inner ear problems, diabetes, osteoporosis, and lying in bed for long periods, prefer sleep-side surgical procedures and illness. Can be treated. Yeah, although medication are not used other than for relief of immediate distress such as nausea, most BBPV cases can be corrected with bedside reposition exercises like the Hapley and the Salmon maneuvers that take only a few minutes to complete. They have high success rate around 80% with only 1 to 3 treatments. These maneuvers are designed to guide the crystal back to their original location in your inner ear. Now, I want to show you a short video I found about the first experiments the inventor of the machine, Mr. Mario Merlo from Italy, did to show how the force is distributed through the bone with high intensity and strength, but in a very short time, so not to allow to the skull to actually move. We can see in this video that when we use the manual mallet, the metal balls they move from their original position. And this is not happening when we use the magnetic mallet. The reason why we have this phenomenon we can see in this graphic. The curve of the manual surgical hammer takes very long time with a relative low force. But when we use the magnetic mallet, we have, since the level 1 to the level 4, a very high force from the machine in a very short time. This take much higher force applied in a very short time influences only the bone mass on which the doctor operates. There's a second video I'd like to show you, and it's about a research by Dr. David Cross and his staff from the University of the Illinois, where the magnetic mallet was compared with the traditional hammer in a similar experiment, where, in this case, the value of the forces were analyzed with a finite elements analysis software to study the stress propagations of the vibration and their directions. They had the same results. The shock is very low compared with the efficacy and the power of the osteotome, and remain very localized to the place where the shock is given to the skull. So, why I use the magnetic mallet? It is faster. The magnetodynamic device, compared to the classical surgical hammer, manual hammer, produces a more powerful energy with high accelerations in a very short time. It's more ergonomic. I can use the mallet with one hand or both if necessary, with more control. I have more visibility. For the reason it is not necessary to irrigate, I have better visual control of the instrument. It is more precise. The forces are perfectly axial to the tips with no influence from the different bone densities of the bone. I have more comfort for the patient. The forces are focused in the proximal area of the tips, with no dispersion through the surrounding bone, and is more conservative for the reason why it doesn't cut like boars do, but expands and pushes the bone. The magnetic mallet thus preserves existing bone and enhances its volume, keeping the vital cells and the growth factors inside of the bone not needing irrigation. Let's talk now about the literature that is specifically behind the magnetic mallet. The first article is in the 1881 from William Gibson Harlington Bonville, who invented the first electromagnetically operated dental plugger to perform dental amalgams, and the idea came from a telegraph machine in operation. But since the 2012, when the machine was invented, until the 2018, we have only few articles specifically about magnetic mallet or surgery procedures performed with this device. The first article is from Roberto Crespi, Paolo Caparé, Enrico Gerlone from 2012, and they compare the hand mallet against the electrical mallet in the type 3 or 4 bone. 55 implants on 36 patients and with 24 months follow-up, and they reached the 96% rate. Two patients claimed BPPV with hand mallet, but the vertigo remitted spontaneously after 1 day. The use of magnetic mallet provided some essential clinical advantages during surgical procedure in comparison with the hand mallet. When needed, sinus lift was performed, and the insertion torque was around 30 Newton for each implant. The patients in the test group presented no symptoms at all of BPPV, and the surgical procedure was faster in the test group, and the implant bed preparation was more precise with magnetic mallet. The main height gain for the sinus lift was from 4 to 6 millimeters, so according to the literature for this kind of procedures. In the next slide, we have a similar case I did in my office. The patient was missing the two molars. The extraction were performed 2 months before, and in the CBCT we can evaluate the type 3 and type 4 bone. So in this case we used the magnetic mallet directly to the bone without using any burrs. This is because of the kind of the bone that was very soft. The procedures, the prosthetic procedure was done one stage with using directly the healing abutment and the suture. After 3 months, we can see the healing after the impression and the definitive, the permanent abutment delivery, and the final crowns in place with the final panoramic of the patient. The second article is from the same authors. In the year 2012, the comparison was between hand mallet and the electrical mallet, but in case of immediate loading. The bone was type 3 or type 4 bone, 138 implants, 25 patients, 24 months follow-up, and 94.93% of success rate. Two patients claimed BPPV with the hand mallet, remitted spontaneously after 1 day. The result was the same of the other article. The use of the magnetic mallet provided some essential clinical advantages during surgical procedures in comparison with hand mallet. And the patient in the test group presented no symptoms of BPPV, and the surgical procedure was faster in the test group, and the implant bed preparation was more precise with the magnetic mallet. The main gain of height for the sinus lift was 4 to 6 millimeters, as the other article. Okay, let's go in my office, and this patient needed to be extracted in tooth number 5 because of a fracture. So we did the same thing of the article. We extract the number 5 and we perform the osteotomy using the magnetic mallet, and we put 2 implants in place number 4 and number 5 with immediate loading, immediate temporary, using temporary PEC abutment, and the provisional was delivered in the day of the surgery. After 3 months, we can see the healing of the tissues, the buccal bone that is preserved, and the interproximal bone peak still present in place. The tooth number 6 and 7 are about 2 years follow-up right now. We are finishing this case right now. In the next article, the same authors. The article is from 2013. They compared end mallet against electrical mallet in fresh extraction sockets with the simultaneous osteotome sinus lift. They put 70 implants on 32 patients with the article is about 24 months follow-ups with a 98.57% of success rate. In this article, the electrical mallet represents a fast and accurate instrument for placing bone expanders in fresh socket implants and simultaneous sinus floor elevation to avoid patient distress. In this article, also, the sinus lift was performed displacing the crestal bone toward the sinus floor, and the apical portion of the implant was placed in the augmented space into the sinus. The main height gain for the sinus lift was 4 millimeters, and they didn't have perforation or BPPV. So back to my office, and the patient needed to remove the tooth number 26 or 14 because of the root resorption and pain. So the hopeless tooth was removed, and in the residual bone between the roots, I tried to reach primary stability using the magnetic mallet, performing the crestal sinus lift and inserting 1 implant. In this case, I put directly the healing abutment and the collagen sponges with no grafts around in the residual gap. This is the X-rays immediately after the surgery, and after the healing we took the impression, and a final crown was delivered. This is the same patient in the lower jaw in a fresh extraction socket with no graft. We had the same healing of the bone around the implant. We can see the modification of the bone and the final. The final prosthesis was delivered 3 months later. In 2014, same authors, and mallet against electrical mallet in cases of split crest and immediate implant placement. 118 implants on 46 patients. The authors performed 46 split crest, 24 months follow-up, 98.31% of success rate. The minimal crestal width was between 2.5 to 3 millimeters, and the magnetic mallet device had a better bone condensing efficiency, especially in softer bone. Because of the magnetic wave and the subsequent shock wave induced axial and radial movements applied on the tip of the ostomy with a fast energy preventing patient distress. In fact, no one presented the BPPV. The final ridge width was between the 5 to 8 millimeters. One patient in the control group presented symptoms of BPPV that remitted spontaneously in 1 day. The main height gain for the sign of lift was like in the literature from 4 to 6 millimeters. This is a patient in my office who needed to restore the incisor area of the maxilla. So we started from the tooth number 10, where we can see a huge concavity in this area, an area that has to be augmented because of a big lack of gingiva and bone. So I performed a split, a partial thickness flap, and then using the beaver holder and the split tip and expander tips from the magnetic mallet kit, I was able to insert an implant in the same surgical time of the split crest, and in the same time I put the healing abutment in place. So I did a one-stage surgery for this implant. After 3 months, we can see how well the tissue has healed with the healing abutment in place and without the healing abutment in place. So we took a provisional abutment, a peak provisional abutment, and we put it in place, and I delivered a new provisional to go ahead with the treatment plan. In the next article, we have the same authors with Bruschi and Gastaldi more. They did a study about hand mallet against electrical mallet in split crest and immediate loading implants. 93 implants, 36 patients, 24 months follow-up, and a 98.92 success rate. The minimum crestal width was 2.5 to 3 millimeters. Like the other one, the beaver and the bone expanders were directly attached and pushed by the electrical mallet, like I did in the clinical case before. The torque reached was 35 Newton minimum, and the provisional were in centric occlusion, avoiding lateral contacts. And after 3 months was delivered the final restoration. The mean value bone loss risk, seen was between 1 to 1.5 millimeters. This procedure prevents the need for only grafts taken from the hip, the maxillary tuberosity, symphysis of the chin, or the external oblique ridge, preventing postoperative morbidity associated with bone harvesting. Let's see now an interesting case of this lady that wanted to restore the tooth number 8 and number 9 for the evident bad looking of the tooth, of the teeth actually. From the baseline X-ray and the CBCT, we can observe a moderate resorption of the buccal plate of the tooth number 9 and the project of the implants in the area. So we extracted the tooth using the mallet, very conservative extraction, and we starting to use the expander tips of the mallet to perform a bone splitting and transferring the bone from the central area for the palatal area to the buccal zone of the area, so to insert the implant and with the optimal primary stability and with the optimal insertion torque. In this case, I didn't perform any I didn't put any biomaterial in the gap, only collagen and the bone that I transfer from the center crest to the buccal area of the crest. So I used a temporary abutment in pick that I transformed inside of the mouth and refined outside of the mouth, and then I delivered the 2 provisionals. After 3 months, this is the final aspect of the crown just delivered. In this article of 2016, the same authors, made a study about delayed implants in a maxillary region where hopeless maxillary molar is inducing large bone defects after extraction. They recorded CBCT before the extraction, 3 months later, and 3 years later, implant insertion with magnetic mallet. The magnetic mallet demonstrates that the expander procedure changes the anatomy of the bone size residual from the first month from the bone healing after tooth extraction. 40 patients, 40 implants, and 100% success rate at 3 years. They demonstrated that increased bone-to-implant contact ratio in the early phase after the implant placement provided an enhanced primary stability. During surgical procedure, magnetic mallet delivered a more precise control of osteotome of the entry direction or directionality of the tip into the bone, not influenced by the different density of the bone. No patient had any. So, back in the office, the patient need to be replaced the tooth number 6 and tooth number 14. So we used the minimal flap approach, no burrs, only osteotome and implant insertion with the healing abutment in type 4 bone. The X-ray is at the moment of the implant insertion. Actually, it was not performed the crestal sinus lift like looks like, but the previous the pre-existing lesion, the reason why the tooth was extracted, actually did the crestal sinus lift. So actually I founded the bone that I manage with the osteotomy technique, and that's it. But on the other side, on the tooth 14, actually I did a crestal sinus lift. In this case, I performed the punch technique, and the same punch, the same gingiva was re-nexted like a CTG on the buccal area of the implant. We'll see that later. Here the osteotome was performed directly in the crest, and the bone was translated into the sinus. Collagen sponge were used, and the implant was inserted with the optimal primary stability. So I decided to put the healing abutment and the auto CTG. It's like a roll flap. Started from the puncher technique. This is the X-rays at the moment of insertion of the implant, and this is the healing, the final abutment, and the final crown. This is the final panoramic and the final photo of the mouth of the patient. Very interesting is the X-rays of the tooth number 14, where new bone and new cortical was reached after 6 months. The last article is from 2018 from Totti, Barrone, Marconcini and Covani. It's about a blade form implant that I'm not using, but where the bed preparation was performed using the piezosurgery devices and the placement was achieved with the use of the magnetic mallet. They've got from this article that a good levels of primary implant stability could be achieved by the use of magnetodynamic devices such as the mallet. So, at the end, which are the application of the magnetic mallet? First, split crest. Then, crestal sinus lift. Dental extraction. Osseodensification. Implant insertion. And crown remover. Let's see more, and let's go back to the private office where we have a lady with missing tooth number 3 and 2. On the CBCT, we can see that we need to perform crestal sinus lift on both of the implants in the type 3, type 4 bone. So I removed the residual. It was present from an older extraction and designed on the crestal bone two round shape with a normal hygiene periodontal tip that actually is a piezosurgery unit. Then, with the magnetic mallet tips, I achieved the osteotomy necessary to insert the two implants with one-stage surgery. That means I reached high primary stability to screw the conical connection of the healing abutments. Same patient, she had to remove tooth number 12 because of a fracture, so I did an immediate implant, expanding the bone crest using the magnetic mallet with no graft on the buccal side. I performed an immediate temporary with an immediate loading implant. And in this slide, we can see the permanent abutments on implants 3 and 2, the permanent abutment on the immediate implant number 12 with a nice buccal aspect of the tissues, and the implant number 14 that the patient did in the meanwhile. It was an immediate implant with same protocol using magnetic mallet and one-stage surgery and no graft. In this slide we can see the permanent crowns on both sides, occlusal view and lateral view, and on this last slide we can see the final RX of the area. Another baseline of a clinical case, tooth number 6 missing, where we need a crestal sinus lift, and teeth number 20 and 19 missing, where we need a split crest or at least bone expansion. The RX after the surgery of the implant number 6 and the one-stage surgery of the implant number 19 and 20 with the post-op RX. The healing of the implant number 6 with the RX of the 2 years follow-up from the delivery of the permanent crown, and in the lower jaw the healing of the area of the implants number 19 and 20 with the permanent abutments. Here we have the final crowns, lateral side, and the final panoramic X-rays of the patient. Next, tooth number 14 has to be removed because of the root fracture and consequent abscess. In this slide about the surgery, we can see that I used the magnetic mallet for the extraction of the fractured residual root. And after that, I've used the osteotome tips to create the ideal prosthetic position of the post-extraction implant, achieving at the same time the primary stability to insert a one-stage implant. In this case, on the buccal side area, I've inserted biomaterial plus collagen membrane exposed to gain keratinized mucosa. The healing of the area, the X-ray with the graft still in place, and the impression. The final aspect of the permanent abutment with the very nice aspect of the keratinized mucosa, the final crown, and the final X-ray. The last case I want to show you is about a patient who had to remove an implant, tooth number 2, and insert 2 implants at tooth number 3 with the crestal sinus lift and number 4, where we used the magnetic mallet both to extract the root and to expand the palatal portion of the residual bone to insert the implant without any grafts material except for collagen sponges. When I removed the implant, there was also a communication with the sinus that I closed with collagen membrane and primary closure of the flap. As we can see from the surgery pictures, I've used the same techniques I've used before, creating a round shape on the crestal bone between the cortical thickness to facilitate the action of the osteotome and perform the crestal sinus lift. The one-stage implants in place, the primary closure of the flap at the place of the communication with the sinus, and the healing abutment in place. Here we have the final panoramic X-rays at the time of the delivery of the crowns on the right side and the 3 years follow-up control X-rays in the left side, here at the higher magnification. So we have seen until now that the magnetic mallet, often compared to the piezosurgical device that we have known since 1997, is a newer technology that performs the same procedures in a safer, faster, and minimally invasive way, performing with very high accuracy the following procedures: extraction, including ankylosed or wisdom teeth, ridge split, crestal sinus lift, implant placement, crown removal, and osteodensification. At the same time, it is important for me to say that I love to use the magnetic mallet in synergy with sonosurgery, osteodensification densa burrs, and manual expanders during every surgical procedures I perform every day of my clinical practice. Thank you very much.